We are the government agency, so I'm the executive director of the agency, and our staff administers the hospital budget program, the revenue increases under contracts. So we have contracts with each of the hospitals, and we have an approach to update those revenue budgets on an annual basis. We do that according to the contract and policies of the Health Services Cost Review Commission. So some of the policies are, for example, performance measurement of quality, and we add or subtract from the hospital's revenue depending on how they did on their quality performance.
Is that a little bit punitive? Or
well, if they do well, they get revenue added. If they do poorly, they get revenue taken away, because we really want them to pay attention to quality and to follow the mantra that better quality attracts more money. So it's kind of getting away from the old fee-for-service model that just kept paid more for bad. The actual fee-for-service model pays more for bad quality, because if you need more services because something bad happened to you, it pays well. Well, this model is turning the tide on that and saying, hey, poorer quality isn't going to pay better. It's not going to pay as well. So there's those kinds of adjustments that are being made to revenue budgets. We're increasing the revenue budgets for inflation and for some of these investment dollars that we talked about. And we also are making adjustments for service shifts. So particularly in the urban areas, if services are provided in a hospital in one year and they move to another hospital in the next year, we need to be able to move the money to whichever hospital is taking care of the patients. So we have a commission of 7 commissioners over top of our staff, and the commissioners approve all of the policies that we administer. And if there are things that are outside the normal course of administering the contracts, the commissioners will get involved in approving changes for those types of issues as well. All of the programs were based on a fee-for-service based model. So the doctor is paid a fairly low amount for an office visit, and in order to make their economic model work in the office, they have to have a lot of office visits. So sometimes that's not really conducive to what you need to do with a chronically ill patient. Or there really weren't a lot of payers who would pay for home visits by a doctor. And just think about how much time that would take to do a home visit. So the model is really is being redeveloped, in the context of the focus on, well, let's deploy more money into these services, and if we are able to improve the quality, then we'll have more money to invest back in the support practices for the primary care. We'll have some money to help extend the time that they're able to spend with patients. And until January 1 of this year, Medicare did not have a fee for care coordination in the primary care office. On January 1 of this year, they made the biggest change ever in the fee schedule for doctors, and they introduced a fee for primary care coordination, so that the doctor can get paid approximately $40 a month for doing care coordination for chronically ill patients. And the patient doesn't have to be there in person. They can be working with them on the phone. The office can be working with them on the phone to help monitor their condition, to work with case managers, and to do other things for chronically ill patients. And about 60% of Medicare patients actually have 2 or more chronic conditions. So there's a lot of work to be done. and about 14% of the Medicare patients contribute to about half of the Medicare costs. So with that 14%, there's especially a lot of work to do with the chronic condition. So, it's really an exciting opportunity where Medicare has come together with this. Payers like Care First have come together with patient-centered medical home programs. And now with the new all-payer model for Maryland, which is something that has been recently introduced into Maryland, the hospitals are also focused on creating care coordination, especially for this 14% of patients who are really patients that visit the hospital more frequently. So they're very focused on it. So, now we're getting a concentration of focus of how do we improve the care coordination and reduce the impact of chronic conditions on our most critically ill individuals. Maryland has had an all-payer model where the Health Services Cost Review Commission, that's the agency that I work with, has been setting hospital rates that are paid by all payers in the state since 1977. So
that's when the waiver.
That's when the waiver was put into place, and we initiated a new model on January 1, 2014, focused on this opportunity to improve health care, to reduce the growth in hospital expenditures, and to reinvest the money in care coordination. So that was something that we did on an all-payer basis, a lot of it because of our history of coming from an all-payer model. But also, it's exactly the same thing that some of the private payers were trying to do, for example, Care First in their medical home. So I think that's really the impetus for doing it on an all-payer basis, but it is being done around the whole country right now with accountable care organizations who are also focused. And about more than 25% of Medicare enrollees are being taken care of now in the country by doctors who are in accountable care organizations. In the old mantra, they were responsible from the patient from door to door. But now that's not a very good strategy because if a person gets sick outside of the hospital and they have to come back to the hospital, that actually, it's not good for the patient, and it also increases the cost to the hospital. So it is a big change in the way of doing things. On the Eastern Shore, the new model started earlier back in 2011. The state had started experimenting with the new model, and they particularly wanted to apply it to rural areas where it would stabilize the financing environment to allow the changes to take place. And so that happened in 10 rural hospitals in 2011. And then we implemented that model for all hospitals in 2014. But it takes a while to figure out how to operate under the new model and really to get all of the systems in place for changing the care delivery and getting more community-based care delivery. It's an issue particularly for rural hospitals. It's around the country. And in our rural hospitals, because of this revenue model that was put in place in 2011, are more stable than rural hospitals around the country, because a lot of them didn't get the benefit of that model and their days dropped, and now they're struggling. And there's been a lot of struggles around the country. The federal government is devising some strategies around that, but when those days drop, then we need to have the stability of a revenue model like the ones that we put in place in the rural areas of the state. But we are extremely hopeful that more patients will not have chronic conditions affect them so that they have to go to the hospital. It would be very good if we can deliver physician care and nursing support to the homes instead of having people end up in the hospital. So we're very, excited about that opportunity. And I think, there's a lot of talk around the country that there's, folks around the country have said that there's 30% of hospital utilization that is avoidable. I don't know that we'll ever get to exactly 30%, but I do think that the avoidable utilization percentages are pretty significant. But you do have to invest money to get that utilization out. So it's not like your costs are going to go down by 20 or 30% because you have to have care coordinators and you have to have more community-based care. So the costs aren't going down by 30%. The other thing that is happening with that space, if you will, that's freed up in the utilization is we have an aging population. So there are going to be more hip replacements and there are going to be more outpatient procedures. So it makes space in the cost profile to address an aging population and provide the care that we need with the aging population. We've added years onto the Medicare trust fund solvency by starting to tackle these issues at the federal level. So part of what we're trying to do is increase the solvency of the Medicare trust fund to take care of an aging population. So that's the second thing. Then the third thing is we've got a lot of new things coming on board that are going to continue to improve care. For example, cancer care is continuing to improve. And some of the cancer care improvements are expensive. So we need to make space in the budgets by reducing avoidable things so that we can continue to invest in better care improvement in the system. And some of those new care improvements are actually reducing, going back to that hospital inpatient utilization, they're really reducing hospital inpatient utilization. So for example, there are now new chemotherapy drugs or radiation therapy procedures that are actually eliminating surgeries. So that keeps driving the inpatient hospital utilization down, but the outpatient cost is going up. And so our new model is really trying to say, hey, we need to invest in the things that are going to continue that process of getting the inpatient utilization down so we can afford the chemotherapy drugs, so that we can do the additional hip replacements, so that we can pay for care coordination. So it's all tied into that, into keeping the Medicare trust fund more solvent. It's now projected to be solvent till 2030, so it's getting better. And so that's a good thing. And I've actually worked around the whole country. I've been in every state, and the opportunity here is to really do it in an organized way where the investments can be afforded. And so being able to put those investment dollars in place and not take money away from the hospitals when they do the right thing, but to free up the money for investments, it's really an incredible opportunity here in Maryland, and I'm really bullish that the hospitals are going to work to invest the money wisely and really improve the chronic care in Maryland. So I'm bullish, because the other model wasn't working too well, and I just can't fathom continuing a model that doesn't really support Medicare patients when we have so many people getting to we already have a lot of Medicare patients, but we have a lot more people, including myself, who aren't far away from Medicare, and we really need the support systems in place. So I think Maryland is lucky.